some time. Any questions?
See, there's a question regarding what are the, how do the new injectors perform? First and foremost, I would like to give you a take-home message that just because something is new, you have to try it or no. What I do is any lens system that I'm comfortable with, very smooth lens delivery, and there has been no issues with the cartridge getting entangled within the piston of the injector or any wound-related issues. I would continue with that particular delivery system. Never always ensure that your incision size is never too tight. The company people will try to tell you that this is a sub 2 millimeter incision or sub 2.2. You must figure it out yourself what exactly is the comfortable incision size you require to deliver the lens without any difficulties. Never have a tight wound. You may have a tendency to have a very small wound, and the lens goes through into the eye, but in the process the incision gets really damaged beyond you have to put multiple sutures to open it. Please do not do that. In certain situations, the incision size should be longer than what exactly is desirable, what is recommended. For example, in a very soft eye, an eye that has a posterior capsular zonular dialysis or a post-vitrectomy eye. These are soft eyes. So instead of really struggling to push the cartridge in and in the process the globe collapsing, you need to have an incision which is little maybe a millimeter or so larger than what is recommended for smooth entry into the eye.
Thank you. Dr. Tamil Rasi, please.
I'll be talking about just two points, which is force of hydrodissection. If we are too vigorous without the capsular bag distension, if it is a large rhexis and it's a soft cataract, it has a tendency to prolapse out. As shown previously, if it is a soft cataract, we can utilize that as a phaco flip technique. But if it is going to be a small rhexis, as here, and the AC is not burped out of the viscoelastic, first wave of hydrodissection is done. And the second wave, you can see that the lens is moving forward. There is a widening of the rhexis margin. AC becomes shallow and the iris prolapses. This is a typical capsular block syndrome. Here, we should let out the fluid inside the bag gently and then only reposit the iris. Otherwise, because the posterior chamber pressure is high, the iris will not go back. So here, the surgeon is using a vigorous decompression. And with this, the capsule has blown out, and you can see that the equator is seen. So the PC has happened, and the nucleus is almost to drop. So this is before and after picture of the capsular block syndrome. So with vigorous hydrodissection, you can see that there is a widening of the rhexis margin and the iris prolapse. And the last slide is when to avoid hydrodissection. As we all know, in case of PPC and traumatic cataract, where we expect the capsule to be compromised, and post-vitrectomized eyes and post-intravitreal injection where multiple injection has been given, where we suspect PC integrity, do hydrodissection. Otherwise, we'll end up in a pupil snap sign, where you can see this momentary constriction. This is because the PC has given away and the nucleus sinks down, so we see this momentary constriction of the pupil. Thank you. Thank you, ma'am.
So really nice presentation. So coming back to our discussion on the wound construction, I think that was a very well delivered talk. There are a few points I would like to mention here. That please do not shy away from putting reinforcement sutures. Sometimes the incisions are borderline incisions, slightly leaky, and you may do excessive stromal hydration. In the process, you may end up with decimate membrane detachment. So whenever you feel that you're dealing with a borderline leaky incision, particularly if you have a PC rent or zonular dialysis, post-vitrectomy eye, don't hesitate to put a tenon suture. And very rarely I have even put a suture for the paracentesis incision. It's very, where there have been very soft eyes and the wound was not very stable. So that is something that I wanted to tell you, that you please don't hesitate in putting incision. As goes the incision, so goes the surgery. If your incision is complicated right from the beginning, if it is too wide incision, too shallow incision, particularly in IFIS kind of situation, you will be ending up with problems. So please use a sharp keratome, making sure that you have a very good incision, and subsequently the surgery would go up extremely well. The talk on rhexis and hydrodissection was very comprehensive. There are a few points that I thought I'd like to mention. is whenever you have a tendency to rexis running to the periphery, don't use HPMC, go back to a cohesive OVD. All right, and then don't just inject in the anterior chamber in the center, inject in the periphery, before the peripheral to where the rexis has a tendency to run away to. So inject, deepen the anterior chamber there, and then you come to the periphery, come to the center. So that is important. Second thing is as intermittent cataracts, I thought the primary rexis in situations where the rexis ran away, was a little larger. So don't aim for a very large rexis. 2 to 3 millimeters is good enough. Anything less than that, you may have difficulty in decompressing the capsular bag. So maybe 3 to 3.5 millimeters, the primary rexis after cortical aspiration, I think is a good idea. And Brian Little rexis salvage technique is definitely very, very useful. Where we saw the canopiner converted into, the rexis converted into canopiner. I think if you had used the Brian Little rexis salvage technique, perhaps, if you had been lucky, we would have been able to retrieve the rexis running away. And please remove the OVD. If you have used a cohesive or a very good high molecular weight dispersive OVD, before you perform hydrodissection, please burp the incision, remove some OVD from inside the eye, and then go ahead with hydrodissection. IOL insertion, stay with the lens that you're comfortable with. And before you go into the patient's eye, use dummy lenses. At least 3-4 dummy lenses should be used under the microscope and see how the lens behaves. As the lens passes through the delivery system, everything you need to understand. Then only take up a live patient with a new injector system. So I think since we are very close to the closing time, it was a wonderful meeting.
I request
lovely
Dr.
talks.
Tamil, please come up.